Good morning, everyone. Today's seminar is on drug-induced movement disorders. Myself, Dr. M. Shivakumar, and my moderator is Dr. Syam, sir. Today's scheme of presentation is we'll discuss the drug-induced movement disorder under following headings: classification, drugs causing disorders, pathophysiology, and the clinical disorders per se, and their management. According to DSM-5, the classification of drug-induced movement disorders is it's classified into medication-induced acute dystonia and acute akathisia, neuroleptic-induced Parkinsonism, other medication-induced Parkinsonism, neuroleptic malignant syndrome, tardive dyskinesia, tardive dystonia, tardive akathisias, and medication-induced postural tremors and other medication-induced movement disorders. This is classification based on DSM-5. Other medication-induced disorders, certain acute, subacute, and chronic. Acute drug-induced when the drug exposure duration is over 2 days. Subchronic when the patient undergoing long-term therapy and presenting with drug-induced movement disorders. Acute to subacute drug-induced movement disorders. Under this, there are acute dystonic reactions, akathisia, drug-induced Parkinsonism, neuroleptic malignant syndrome, serotonin syndrome, drug-induced tremors, hyperkinesias. In tardive syndromes, this definition based on according to DSM-5, the tardive, the word is Latin word and it comes from tardus, which means late onset, or you can call it chronic syndrome. This is a chronic syndromes. This is an involuntary acidoid or coriform movements lasting for at least a few weeks, developing in association with the use of any neuroleptic medication for at least few months, and disorder persisting beyond 4 to 8 weeks. And there is no consensus criteria for the maximum interval between the withdrawal of dopamine receptor blockers and the onset of movement disorder. Tardive syndromes are classified into tardive dyskinesia, tardive akathisia, Williams syndrome, other tardive syndromes like tardive tics, tardive myoclonus, and tardive tremor, and the combination of these disorders. The patient can have a combination of the above dyskinesia, dystonia, akathisia. Risk factors are this drug-induced movement disorders are more seen in older age, particularly more than 55 years, and other risk factors like female gender, longer cumulative antipsychotic exposure, history of any acute extrapyramidal symptoms, diabetes mellitus, dementia, and African American ethnicity. Coming to drugs that is causing the drug-induced movement disorders, first we'll see dopamine receptor blocking agents. We can see the first generation antipsychotics classified based on the structures, phenothiazines, thiazanthines, butyropheноnes, heterocyclic compounds. In phenothiazines, chlorpromazine, triflupromazine, thioridazine, trifluoperazine, flufenazine. These are the common drugs in phenothiazine class causing drug-induced movement disorder. And thiazanthines, the drug is flupentixol. Butyrophenone, haloperidol, which is a very the potential drug to cause this movement disorder, drug-induced movement disorders, and trifluperidol. Heterocyclic compounds like pimozide, loxapine, and levosulpiride. These are the first generation antipsychotics, and they are associated with high risk of drug-induced movement disorders. Coming to second generation antipsychotics, also known as atypical antipsychotics, aripiprazole, ziprasidone, quetiapine, and first generation receiving generation develop this in this state, clozapine and kidneys, they release within 12 to 24 hours. So the action is short lasting. And clozapine is primarily a D4 blocker more than a D2. So clozapine and quetiapine are the most typical and least associated with drug-induced movement disorder in this class. And coming to aripiprazole, this is a 5-HT2 antagonist and D2 partial agonist at presynaptic autoreceptor. This causes the reduces dopamine synthesis and release and is more propensity to cause the drug-induced movement disorder among the atypical antipsychotics. Non-dopamine receptor blocking agents causing drug-induced movement disorders are dopaminergic drugs, where levodopa and direct dopaminergic agonists, these causing dyskinesias and other movement disorders, and antidepressants like selective serotonin reuptake inhibitors, tricyclic antidepressants, and monoamine oxidase inhibitors. Anticonvulsants like carbamazepine, phenytoin are also can cause drug-induced movement disorders. Anesthetics like propofol, prokinetics, metoclopramide, amisulpride, levosulpride are associated with frequently with drug-induced movement disorders. Calcium channel blockers are flunarizine, synarizine, and melatonin, pegylated interferon alpha. These are the some common drugs, non-dopamine receptor blocking agents causing drug-induced movement disorders. Coming to pathophysiology of acute drug-induced movement disorder, as we discussed this first generation or second generation, the main cause for this drug-induced is D2 receptor blockade. This D2 receptor blockade in nigrostriatal pathway decreases the inhibitory effect on cholinergic interneurons. So actually, these D2 receptors are present in cholinergic interneurons. When these are blocked, this equilibrium shifts to the cholinergic side, and also there is a hypodopaminergic state. This causes a sustained involuntary contraction, leading to dystonias. And the D2, D3 receptor blockade in mesocortical pathways uh, also causes lower dopamine signaling, manifesting as agitation and restlessness, leading to known as akathisia. SSRIs, these SSRIs, as they reuptake inhibitors, increase the serotonergic tone, reduces dopamine release or receptor sensitivity. They modify the receptor sensitivity. Also can cause akathisia. Coming to pathophysiology of tardive dyskinesias. This tardive, as we discussed, so, but there is actually there is in akathisia there is imbalance between the dopamine and serotonergic. Sir. There is hyperserotonergic, so they feel inner restlessness because of the increased serotonin. No, this is mainly for akathisia, sir, not Parkinson's. Mainly more commonly associated with akathisia. Tardive dyskinesia pathophysiology. As tardive dyskinesias are caused due to longer duration of exposure, the chronic D2 receptor blockade causes the compensatory upregulation of dopamine receptors with conformational changes, leading to hypersensitivity states. Even though a receptor is so the receptor is blocked to increase synthesis of receptors, and also there is a neuroadaptation produced enhancing dopamine signaling. These causes increased inhibition of indirect median spiny neurons in striatum and cholinergic interneurons, decreases the cholinergic and GABAergic signaling, and causing persistent hyperkinetic involuntary movements. Here we can see the dopamine hypersensitivity hypothesis causing this tardive diseases, tardive dyskinesias. Here, you can see substantia nigra. This is direct pathway. This is indirect pathway. The direct pathway has a D1. This dopamine modulates through D1 receptor, and the indirect pathway, it is modulated. Dopamine acts on the D2 receptors. As we see, already discussed this. Most of the antipsychotics are D2 receptor causes D2 receptor blockade. So indirect pathway is commonly affected, and direct pathway is spared. See, in the short administration of dopamine receptor blocking agents, there is upregulation of indirect pathway because subthalamic nucleus is disinhibited, uh, and this internal globus pallidus is stimulated, and thalamus is inhibited due to increased GABAergic. Therefore, there is decreased activity. So indirect pathway is activated and decreased activity. But in long-term administration of antipsychotics and chronic receptor blockade, there is downregulation of indirect pathway, leading to uh, disinhibition of thalamus and increased motor output to cortex, leading to increased activity. This causes dyskinesia. So this is one of the primary hypotheses. Next is other causes explained are GABA hypothesis, where this cerebral cortex usually stimulates both median spinal neurons of both direct pathway and indirect pathway through NMDA receptors. This glutamic acid also stimulates NMDA receptors on para. This is frequently spiking interneurons, paravermion, and these neurons in turn control indirect and direct pathway through GABAergic transmission. So this balance is lost when in this dyskinesias. Mainly this feed forward inhibition is lost. So this dysregulation causes dyskinesias. And the other hypothesis, reactive oxygen hypothesis. In this due to long-term blockade, receptor blockade, there is increased dopamine synthesis and metabolism. This dopamine is metabolized by monoamine oxidase and catechol O methyl transferase. During this metabolism, there is increased production of hydrogen peroxide. So this leads to production of hydroxy radicals and damage. Here we can see this hydrogen peroxide in the presence of transition metals, increased presence of transition metals like manganese, iron, copper, zinc, produce hydroxy radicals, and they cause the damage, cause lipid peroxidation, and unsaturated fatty acids are damaged, thereby cell membrane lipid damage. This causing neuronal damage. So this is one of the hypotheses for this dyskinesias. Coming to the disorders, acute dystonia. It is the earliest abnormal involuntary movement to appear after initiation of dopamine receptor blocking agents. It starts within 48 hours in 50% of the cases, and within 5 days, 90% of the patients present, and may occur after the first dose. Risk factors are young males. Usually, most of the disorders occur in elderly, but this is risk factors young males, and if they have history of severe psychosis and IV preparations are having high risk of causing acute dystonia. First generation antipsychotics, haloperidol, flufenazine, and pimozide are have high risk of causing acute dystonia. Other agents like dopamine depleters, serotonergic agents, and dextromethorphan can also be causing this acute dystonia. And prokinetic agents like metoclopramide, levosulpiride, domperidone, etopride, and antiepileptic like phenytoin and carbamazepine are known to cause acute dystonia because they have D2 blocking properties. Acute dystonia mechanism. Dopamine receptor supersensitivity leads to an imbalance between central dopaminergic and cholinergic neurons transmitters in the striatum of the basal ganglia. This is due to blockage. There is sudden increase in dopaminergic release and also increased turnover, which lasts around 24 to 48 hours. But the effect of blocking the postsynaptic receptors fades in about 12 hours after a single dose, and later due to blockade, supersensitivity starts to develop. This presynaptic dopaminergic excess and in combination with this emerging supersensitive postsynaptic dopamine receptors, this is causes increased striatal dopaminergic activity by around 20 to 40 hours after the neuroleptic dose. This is the time where the most of the patients develop this dystonia. Clinical features of acute dystonia. The patients, in these patients, the commonly affected muscle groups are neck, face, limbs, and they can present as a torticollis, trismus, like also known as lockjaw, and oromandibular dystonia. They can present with tongue protrusion, tongue biting, or tongue twisting, facial grimacing, blepharospasm, like excessive blinking or squinting, due to increased extensor muscle tone, backward arching of neck and two heels. They can present with opisternous position, and even oculogyric crisis. It is a paroxysmal conjugate, typically upward deviation of eyeballs. Rarely, the acute dystonia can be life-threatening if laryngeal and pharyngeal muscles are affected. Acute dystonia management. Uh, Immediately, the offending agent stop or modifying the offending agent. Resolve after stopping most of the patient symptoms resolve spontaneously in 12 to 48 hours after last dose. Symptoms can be relieved within minutes. Symptomatic management can be given by parenteral anticholinergics and antihistaminics. IV and IM diphenhydramine benztropine are the first line treating agents for this acute dystonia. IV, if patient is having acute laryngeal dystonia, uh, IV benzodiazepines with IV anticholinergics can be used. For focal dystonic symptoms, local, like first line local injection of botulinum toxin can be used. Yes, sir. For the last slide. Sir, that my mistake. This is a oh, that my mistake. My mistake. Here we can see in this video, this patient was started on risperidone. On the second day, he has presented with a conjugate deviation of tonic deviation of eyeballs. This is oculogyric crisis. He was on risperidone, presented 2 days after 2 days. Self-limiting process. Who will take such a patient for this? When you read that, if it is there in the answer for you should question that sentence. Okay, you can take that those two last slides again. This is a 19 years old boy. When this is no specific medical history, was presented with gastrointestinal symptoms like nausea, vomiting, and abdominal pain. He was treated with prokinetic slebopride, which has a D2 antagonistic properties, and he presented next day with the tonic deviation of neck towards right side, and which was and also complaining of pain. When asked for, he was able to turn his neck, but with increased pain. So this is an acute neck dystonia presenting with the torticollis. He was able to turn to left side when asked for. Coming to acute akathisia, it is defined as abnormal state of excessive restlessness, a feeling of a need to move about, and they have relief of symptoms on moving. The patients can have a sensory features and motor features. Sensory subjective features of feeling inner restlessness or tension. This leads to pronounced urge to move. And during the due to this sensory inner restlessness, patients have motor features like inability to sit, stand, or lie still. They have semi-purposeful, stereotypic and repetitive movements like pacing, walking, body rocking or shifting weight, leg rubbing, fidgeting, squirming or toe tapping, and repeating touching. These are the symptoms due to inner restlessness. This kind of motor features can be seen in this acute akathisia. Here, in this patient was who was started on antipsychotics, as presented with constant movement of both limbs. This is one kind of motor manifestation of acute akathisia. Pathophysiology of acute akathisia. There is a reduction in dopaminergic projection in mesocortical pathway leads to increased locomotor activity. And risk factors are mainly first generation antipsychotics and using in high dose and frequent dosing. And also drug-induced Parkinsonism patients will have increased risk of this having this akathisia. Other agents causing are dopamine depleters, cocaine abuse, and SSRIs. Coming to treatment, it is a self-limiting disorder and on discontinuation of neuroleptics, and well controlled by anticholinergic despite continuation of neuroleptics. Even if we want to continue and if it is mild akathisia, it can be controlled by using starting anticholinergics. Also, we can treat with amantadine, beta blockers, and clonidine. Treatment. Drug-induced Parkinsonism. Uh, this is a dose-related side effect due to dopamine receptor blocking agents or dopamine depleting drugs. And it's more commonly seen affects women and older individuals. And it is reversible when the medication is reduced or discontinued. Reversal may take several months in few patients. Pathophysiology here, this is to blockade of dopamine receptors by antagonist and or due to depletion of presynaptic monoamines. This causes a deficient dopamine state leading to Parkinsonism. And calcium channel blockers like flunarizine and cynarizine, they pass the blood-brain barrier and inhibit and reduce postsynaptic dopamine receptors, thereby causing this symptoms. CCB also inhibit tyrosine hydroxylase enzyme activity, causing decreased production of presynaptic dopamine. This phenomenologically, the symptoms of Parkinsonism are similar to idiopathic PD, like having high frequency tremors, and they can have symmetrical or asymmetrical signs. The 3 to Spectrin that is used in differentiating this drug-induced and tremors and with idiopathic Parkinson's disease, or it is an exacerbation of a subclinical PD. Showing the images. Drug-induced movement disorders is a presynaptic striatal neurons are intact, so dopamine uptake will be normal. But in IPD, idiopathic Parkinson's disease, there is a decreased dopamine reuptake. So there is a in the scan we can see that asymmetrical decrease uptake of the strata. Drug-induced Parkinsonism. This patient was started on antipsychotics. Later, he presented with right hand. Here we can see right hand rest tremor, and also subtle like mild tremor in the left hand also. This is similar to what we see in Parkinson's disease. Here, this DAT scan, usually then the nigrostriatal DAT banding is normal. See, we can see the uh, complete uptake of the nigrostriatum here, dopamine uptake, this DAT isotope uptake. And in the here we can see the asymmetrical. This is asymmetrical uptake and this is symmetrical. Reduced in putaminal regions in the patients with Parkinson's disease. This is a Trodat spect. Normal preserved tracer uptake in the bilateral basal ganglia, and here is the asymmetrical, right more than left. Treatment of Parkinsonism, anticholinergics are effective in reducing the severity of symptoms. If dopaminergic drugs are effective, there is but dopamine ineffective because these are the drugs binding to this receptor cannot be displaced by these dopaminergic drugs. Levodopa has a role in reversing Parkinsonism for if the cause is dopamine depleters like reserpine. In such cases, levodopa can be used for treatment. Primary treatment is drug withdrawal, and the other management based on supportive management. And yes, ma'am. Clinically, we see for 1 year, more than 1 year. No, ma'am. That's why we have to treat this patient and withdraw the drug and look for the improvement. Then, if it is offending drug, few weeks to months takes time. Even if drug is withdrawn, few patients may have prolonged Parkinsonism symptoms. It is a degenerate underlying. It's unmasked by the drug. Next is neuroleptic malignant syndrome. This is an idiosyncratic reaction, and it has an abrupt onset, manifests within 24 hours and reach maximum within 72 hours. And this can be it's been a life-threatening condition. Risk factors for neuroleptic malignant syndrome: dehydration, exhaustion, agitation, catatonia, and history of prior episodes of NMS. And if there is a rapid escalation of dopamine receptor blocking agents, and if you use multiple dopamine receptor blocking agents, increases the risk. And also, if concurrent dopamine depleting agents like lithium and like dopamine depleting agents, lithium, SSRIs, SNRIs, if combined, increases exponentially the risk of NMS. And haloperidol is one of the common cause for this. Most of the cases, half of the cases are reported cases of NMS are due to haloperidol. And risk factors, mainly NMS, young males and recent weight loss, such risk factors, they are prone for NMS. And there is no relation with duration of therapy. Coming to clinical features, neuroleptic malignant syndrome patients can have hyperthermia and other autonomic dysfunctions like tachycardia, diaphoresis, and labile blood pressure. They can have generalized lead pipe rigidity with tremor. They have multiple various dyskinesias, dystonias, and myoclonus. There is alteration of mental status, so patient will have agitation, inattention, and confusion. Patients can have dysarthria, dysphagia. And in extreme form, there is patients will have an hypermetabolic crisis, and usually the recovery is within 1 to several weeks. It can be fatal in 20 to 30% of cases. If it treated, the mortality, even in treated condition, up to 5%, the mortality can be there. Treatment is stop the offending drug, antipsychotic drug, and start supportive measures like hydration, electrolyte and acid-based management, and respiratory cardiovascular monitoring, and kidney functions to be monitored. There is a rapid relief of symptoms with use of dantrolene, bromocriptine, or levodopa. This bromocriptine and amantadine should be at least continued for 10 to 14 days, even after the symptoms are resolved, to avoid the relapse. Coming to serotonin syndrome, serotonin syndrome is due to increased serotonin either by synthesis or due to increased release or decreased reuptake, and food containing high tryptophan. Drugs like SSRI and SNRIs, selective serotonin reuptake inhibitors, and norepinephrine serotonin reuptake inhibitors, amphetamines, and meperidine are prone to develop this serotonin syndrome. 5-HT agonist sumatriptan and monoamine oxidase are also associated with serotonin syndrome. This is due to increased serotonin and sustained stimulation of 5-HT1A and 5-HT2A receptors in medulla and central gray matter. This central and peripheral serotonergic hyperactivity is the underlying pathology for serotonin syndrome. Patients present with cognitive symptoms like mental disturbances like agitation, delirium, hallucinations, confusion, hyperactivity. And neuromuscular symptoms in this syndrome are, they can have an inducible or spontaneous clonus, ocular clonus, exaggerated reflex, hypertonia, muscle spasms, rigidity, tremors, and they can have restlessness and also rhabdomyolysis. Due to autonomic hyperreactivity, patient can have features of fever, diaphoresis, diarrhea, flushing, and increased or decreased blood pressure. Can have tachypnea, tachycardia, and mydriasis. The treatment is stopping the offending drug. Mild to moderate cases usually resolve on their own within 24 to 72 hours. And the supportive treatment, oxygen, IV fluids, and airway support is given. If there is hyperthermia in patients, it is treated with external cooling, and antibiotics are of less benefit because this hyperthermia is due to increased muscle activity. And serotonin antagonists like cyproheptadine and chlorpromazine can be is a specific treatment for this serotonin syndrome. And it's a cyproheptadine is a specific 5-HT2A receptor antagonist, and its dose is oral dose 4 mg, and is a specific antidote. Yes. It exists.
What are key factors? Overall, they are saying hypothermia is there, hypertonia is there, oxidation is there, that is there, also conditions. So, what are the key features?
Mainly drug. The patient is on which drug mainly?
Patients. Again, they will be on that's fantastic. What do they get out on those things?
We can rate how to differentiate because both the situations are almost related. How to differentiate?
The neuromuscular features. This mainly this agitation, hallucinations, and and facial flow.
And which will not be there in a so much diarrhea,
when preparing, this question never came to me.
Coming to levodopa-induced dyskinesia. Levodopa-induced dyskinesia, based on the pattern, it is peak dose classified into peak dose dyskinesias, wearing off or off-period dyskinesia, and diphasic dyskinesia. And in among this, peak dose dyskinesias is the most common, around 80%. Patients with levodopa-induced dyskinesia present with chorea, balism, dystonia, myoclonus, and or combination of these, involving neck, facial muscles, jaw, tongue, and hip and shoulder proximal muscle, trunk, and also limbs. Myoclonus. Levodopa-induced dyskinesias approximately develop after 3 to 5 years of administering levodopa. Because mainly we can see here there is a in premotor stage of PD. After in the advanced stage of PD, there is degeneration of dopaminergic neurons by more than 70%. During this phase, there is a part, the improvement with levodopa also decreases, and if there is abnormal adaptation of striatal organization, so there is and so there is a the improvement with the symptoms with the levodopa also decreased, and also this causes levodopa. This is per se not due to dopamine, but this mainly due to degeneration of all dopaminergic neurons and this abnormal adaptation of striatal organization. Risk factors are young age at onset and of PD, and also low body weight. Associated drugs are levodopa, carbidopa, and entacapone. Female gender has a more risk than male. And a patient is having the more severe scores of UPIDS, they are more prone for developing these dyskinesias. High dose and long duration of treatment.
Duration of treatment is a course, duration of
Yes.
duration of treatment. Actually, the higher duration of treatment is directly representing the higher.
Due to longer pathophysiology of levodopa-induced dyskinesia, long-term administration of levodopa causes loss of striatal dopamine and abnormal synaptic neuroplasticity, leading to overactivity of direct pathway and underactivity of indirect pathway, producing excessive motor movements. Management can be managed with the dopaminergic drugs and non-dopaminergic drugs. Dopaminergic drugs, if there is peak dose dyskinesia, the frequent smaller dose of the dosing can be divided into frequent smaller doses. And if the patient is on COMT or MAO inhibitors, that can be reduced or discontinued. And because these dyskinesias occur during the due to high levels of dopamine, and there is a also switching to immediate resist formulations and adding amantadine for peak dose dyskinesias. Off-period dyskinesias can be treated with long-acting formulations and COMT and MAO inhibitors and dopamine agonists. Diphasic dyskinesias can be treated with levocarbidopa intestinal gel and apomorphine. This is due to apomorphine continuous subcutaneous infusion. So these are highly selective agonists acting on D1, D2. They are useful in diphasic dyskinesias. And non-dopaminergics like amantadine, safinamide, instraderifril are used in treatment of this dyskinesias. Coming to tardive syndromes, this is due to exposure long duration, at least 3 months, and onset within 6 months of the onset of symptoms, and persisting at least 1 month after stopping the offending drug. And cessation or dose reduction of these drugs can trigger or exacerbate dyskinesias that have been masked by these dopamine receptor blocking agents. Increasing this dose agent's dose can sometimes appear to increase the tardive dyskinesia by masking its symptoms. Risk factors are for these tardive syndromes we have already seen: older age and duration of exposure, medication dose, and history of extrapyramidal symptoms due to drugs, and diabetes mellitus, HIV, dementia, female, and African American ethnicity. Classic tardive dyskinesia is a complication of long-term and DRBA therapy. It is due to rapid, repetitive. It is characterized by rapid, repetitive, stereotypic movements involving orobuccolingual areas. Patients present with repetitive, complex chewing motions and like lip smacking and opening mouth, tongue protrusion, lip pursing, sucking movements, and fish-like lip puckering movements. These movements are rhythmic and coordinated. Uh, Patient can suppress these movements if asked to do so, but they reappear again. This movement ceases when the patient is putting food in mouth or talking or placing a finger on the lips. And there are due to the constant lingual movements can lead to tongue hypertrophy, and macroclasia can be seen in these patients. And but patient can keep tongue protruded without darting back into the mouth for more than a half of a minute. That is, motor impersistence is not seen in dyskinesia, classic tardive dyskinesia, because of the movements. Because the movements do not interfere with the basic functions, most of the patients are unaware and present late. They can also have stereotyped hand clasping and distal limbs showing the repetitive patterns like piano playing fingers or toes. And in sitting position, the patients will have a constantly repeatedly movements of legs, flexion extension of toes or foot tapping. If patient is lying down, they can have a flexion or extension of thighs may be seen. Here we can see the orobuccolingual movements involving lips, tongue, and mouth. This is an elderly female treated with antipsychotics, and after discontinuation, she has presented with orobuccolingual chorea. Here is another patient. Here we can see movements of lips, mouth. After prolonged treatment of antipsychotics, and after stopping, the patient presented with orobuccolingual chorea. Here we can see the patients having chorea involving both trunk, upper limbs, and lower limbs, and also having mild oral dyskinesias. This is a overlap combination symptoms, tardive dyskinesia and chorea. Here we can see in this patient, if we like the hands, bilateral hand, there is a finger movements similar to piano playing, known as piano playing fingers. This is one of the manifestation of tardive dyskinesia. Here in this video, we are seeing an 50-year-old male who was on antipsychotics, developed presented with bradykinesia. When asked for, he was testing bradykinesia. He has bradykinesia and hypomimic face. Here's seeing finger tapping, slow finger tapping, and he's having bradykinesia with decreased facial expression. And this patient had a drug-induced Parkinsonism, uh, secondary to tetrabenazis, which was started outside to treat tardive dyskinesias, as that was developed was as he was on prolonged antipsychotic dose. He was started on the tetrabenazine, so he developed Parkinsonism symptoms. You can also see the tremor in the tongue. This patient later, after coming to us, we have stopped the tetrabenazine, but the patient has tardive dyskinesia reappeared. Here we can see dyskinesias of neck, oral cavity, and oral mouth and lips, and the bradykinesia that previously Parkinsonism symptoms now like reduced. Like he was not having any bradykinesia, was able to do finger tapping and opening and closing of hand, but due to withdrawal of this tardive tetrabenazine, tardive dyskinesia symptoms reappeared. There was no bradykinesia, but she was having dyskinesia involving proximal upper limbs, shoulders. This patient was treated with Botox and is in follow-up. Coming to withdrawal emergent syndrome, this syndrome is seen in most commonly seen in children. This after days or weeks after discontinuation of drug, present with chorea involving trunks, limbs, and rarely involving oral region. Like unlike this classic TD, where we can. This is commonly seen in children, and it is a benign condition and self-limiting condition. He's a 11-year-old boy. History of Tourette syndrome was started on olanzapine for his behavioral abnormalities, and we can see he was seeing the piano playing fingers and also chorea involving upper limbs and lower limbs. This is a self-limiting condition with drug withdrawal usually settles. Going to tardive dystonia, it is a sustained involuntary contraction of muscle, can be focal or segmental. Usually progress over months or years. From focal onset can become more widespread. Patient presents with retrocollis or internal rotation of arms, extension posture of elbows, and flexion of wrists. This patient can see was an antipsychotic treatment, presented with, for long duration, he was on antipsychotic treatment, presented with, we can see abdominal muscle contraction, abdominal dystonia, and also neck dystonia. We can see the platysma contraction, along with some dyskinesia involving lips. Yes. He's also having movements in the fingers, piano playing fingers. You can see the platysma contraction, neck dystonia. Sir, can be focal to only started as focal and can get widespread if drug is not stopped. He was treated on started on antipsychotics with underlying psychiatric disorders.
So it is asking what is the natural history of this timing, what will happen in the long run.
If drug is not discontinued, sir, then yes, ma'am. Yeah, you should discontinue the drug.
If you discontinue after but have percent, if the patient is on allopathy, you increase the it's discontinued after say the cardiac scan, it's running on the scan, whatever. You worsen.
Can add,
Improve.
or else we can add a typical antipsychotic.
But medication is responsible for this. So it is not a guideline as a guideline. It's not a step patient. You have to treat it either with protein use or medications, or if it is little refractory, it is not an indication of complete extension. What I do is It's versus for all something general. Even if you withdraw the pen, may continue. But all the previous guidelines, they did not factor in it.
Sure.
There are many expert guidelines or many expert opinions which tell that this drug is responsible. If possible, try switching over to it.
A typical and clozapine can be substituted.
Because this actually this drug is responsible. So if you can, maybe get your person.
Here we can see the retrocollis posture due to neck extensor muscles involvement. Due to this patient had a similar history of prolonged use of antipsychotics. Coming to here we can see the patient is having tardive akathisia and stereotypy. You can hand rubbing stereotypies, continuous hand rubbing stereotypies, and also this akathisia inner restlessness is having leg movement. So this tardive can be coexisted, akathisia and stereotypy. Here we can see tardive tics of face. If you see the facial tics, and also tremors. Here we can see this is a 45-year-old woman was treated with haloperidol for schizophrenia. She presented with vertical lip movements. This is similar to a movement of a domesticated rabbit. So it's known as rabbit syndrome. And this should be differentiated with a tardive dyskinesias, because tardive dyskinesias can, with oral movements, it can have other involvement of other body parts. In this, with rabbit syndrome, it's due to involvement of only the lips. And the differentiating is anticholinergics use anticholinergics are improve the rabbit syndrome, but worsen this tardive dyskinesias. Coming to treatment of tardive dyskinesias, treatment is divided into 3 tiers. The first tier drugs are VMAT2 inhibitors, vesicle monoamine transferrin 2 inhibitors, with having a level of evidence in for this condition. And they deplete the presynaptic dopamine by blocking the package of dopamine into here we can see this is a VMAT, and that green color marked is a VMAT2 inhibitor. If this is inhibited, there is a decreased synaptic package of dopamine, and so this decreases overall dopamine release and reduces the hyperkinetic movements. The drugs are valbenazine. The second tier third tier drugs are insufficient evidence. Levetiracetam, melatonin, baclofen, propranolol, zolpidem, zonisamide. They can cause Parkinsonism symptoms, and also suicidal risk is more with tetrabenazine and deutetrabenazine, because they also inhibit the packaging of other monoamines like serotonin and norepinephrine. So this causes increased suicidal tendency. in these patients use on tetrabenazine or deutetrabenazine. Selectivity, VMAT2 inhibitors. There are other vesicle monoamines, other VMATs and involving. Coming to treatment of dystonia, tardive dystonia. Main treatment is first line is botulinum toxin and clozapine. If a patient is having severe psychosis and having movement disorder, they can be started on clozapine, which is least risk associated with causing this tardive dystonia, and other anticholinergics like benztropine and trifexinidil is beneficial, and VMAT2 inhibitors are also effective in treating this dystonia. If severe cases, the patient should be taken for deep brain stimulation of globus pallidus internum. DBS for both refractory patients of dyskinesis and dystonia, deep brain stimulation of globus pallidus interna has a good efficacy and reasonable safety. And other sites are subthalamic nucleus, and other ablative surgeries like pallidotomy and thalamotomy in very like refractory cases can be tried. Role of anticholinergics in drug-induced movement disorders. These are effective in treating drug-induced Parkinsonism and dystonia, but not recommended in tardive dyskinesias, akathisias, and neuroleptic malignant syndromes. They are started in low effective dose, and after symptoms are resolved, they are tapered gradually. This anticholinergics improves drug-induced Parkinsonism because this in drug-induced Parkinsonism is a hypokinetic disorder characterized by relative excess of cholinergic, the balance shifted towards the cholinergic excess. So this anticholinergic helps in treating this drug-induced Parkinsonisms. But if you see in tardive dyskinesias, a hyperkinetic disorder where there is a dopamine excess, and already there is a relatively shift towards dopamine. If you use anticholinergics, and this will worsen the imbalance, thereby causing the worsening of the hyperkinetic movement disorders.
How you treat an observatory crisis in war? Suppose you are getting observatory crisis, what you do?
You can use anticholinergics.
What injection, what will you give?
Benztropines.
Available
Anticholinergic in the ward.
at least after a session, somebody should be able to tell that how an acute observatory crisis can be treated in the period of war. For our relatives whom disorder is promptly disappear after discrimination, and what are the situations which will not disappear?
Acute acute dyskinesias can this.
You can give benzodiazepine injection. Or maybe
You can ask me to include one of the slides on other transition was so that's so remember in this one, then you have
Like I enlisted drugs in the starting, sir, non-dopamine.
Let us give examples of syndrome disorders which will not disappear.
Should not disappear is acute like dystonia. Acute dystonia, tardive dyskinesias, and tardive dystonias can be prolonged even after this cessation of drugs.
You must have and your knowledge largely equal to what all is symptom. Nothing more than that. Okay, maybe not reading might help.
Okay. It feels like getting prescription. If we give palliative plus try to see it. Say go to giving that.
Yes, ma'am. There are like few like prophylaxis, and they were advising anticoag, but previously, ma'am. But
What is the answer?
yes, ma'am. Like prophylactic, there is no as of.
This one, when in the, if that's a target use part, so you have seen hundred examples of problems with treating one diabetes woman disorder with another. The one which you showed in the video was inevitable because patient had diabetes can see a very severe. Somebody gave it that was the right choice, but patient had diabetes Parkinson's which was more troublesome. Okay, so just like that, anticoagulants is one of the problems with anticoagulants. If you give anticoagulants, that itself can induce so that is one can worsen psychosis. And it is also we now shown that anticoagulants is elderly increase the risk of dementia. Not the cognitive dysfunction associated with anticoagulant use, but it can predispose to dementia. Even you have to lower it. So this. Certain diagnosed moment so that we can use. For example, you can use for dystonia, if you just study dystonia. Prophylactically, that's
And you suspect that the patient was like, the patient you suspect that this is a drug induced so and you have to really search and search for any drug induced.
With it,
And the things you can't be obvious, but you should strongly suspect the drug in certain situations.
like temporal duration of the after starting the drug.
Yes, sir.
phenomenology.
In all your videos, there was some just very common. Which part of the body?
Mainly facial and or a facial.
They all had things which was going back. You have officer on costume and or dog or which is this a mixture of more disorders, more than one medicine. But it's part is part of correction.
Characteristic properties, or going to so in such situations, patient may totally in and then and finally find that he was somebody was somebody. That usually happens because it's that diabetes might be prescribed by gastroenterologist. Because the patient
Maybe they
and drug-induced Parkinson's someone features there will not be usually there's some reason Parkinson's using is there, but drug-induced Parkinson's so freezing is usually very big. Even if it's really Parkinson's, it may be this freezing of the plus freezing of the pure local broken can be search into
Thank you for patient listening. We are stopping the session.